I'm really overwhelmingly impressed by not only the intelligence, but the understanding of all the speakers and actually most of the audience members I've spoken to as well. And you're right, the data is available, but it's not just knowing the data, it's understanding it. That said, the title of both my talks could be, The More I Know, the Less I Understand. I'm going to start with revascularization strategies in patients with severe LV dysfunction. I have no disclosures. Now, with due respect to Dr. Estes, and actually in support of what Dr. Spray said earlier today, guidelines are guidelines, they're not rules. And it becomes, the more you understand, it becomes so painfully obvious that they really don't help you as much as they want to and try to. And this is starting with this. If you go through the guidelines, how is LV dysfunction defined? It's defined by EF of less than 35%. You know, I do have a lot of experience. I've operated on hundreds of patients with LV dysfunction. And it's embarrassing to say that they're all the same, because they're not. If you look at LV dysfunction with AS, that's not so bad. You take it and it goes away. With coronary disease and EF at 35, that's nothing. I mean, I think that's not a big deal at all. If you look at, however, AI, EF at 35, that's bad. If you drop that down a little bit more, it's a little concerning. And patients with MR, boy, you've got two exits, right? So you've got much less afterload. If you have an EF at 35 or less with MR and coronary disease, they're totally different patients, and we need to really understand that if we're going to talk about guidelines. That said, that's not the point of this talk, but I want to start that. So this is only going to look at isolated coronary disease in patients with EFs of less than 35. Well, for LV dysfunction, I look at that in my last Friday's case, just a week ago. I have a 65-year-old guy, admitted with shortness of breath, had non-STEMI, tropes went to 4, creatinine's 1.1, and this is what his heart looks like. Now, they read the EF at like 15%. It's pretty low. We all have to agree it's not 35%. What do the coronaries look like? Well, this single shot tells it all. Has left main, has LAD disease, occluded right that reconstitutes. Okay? Now, I don't always do this, but I'm going to do it just for the purposes, because I want to take an audience poll and I'll make sure to look at the moderators to make sure they're raising their hand in response to questions. I did get a viability study. This is the MR. It was viable. You can see the LV is thick and is contracting. So EF is probably 15%, has some targets, you know, not a super old guy. We have three choices. We have medical therapy, catheter intervention, and surgery. And again, I'm going to look at the moderators and make sure they raise their hands and commit. How many people, raise your hand, would do medical therapy in this patient only? So everyone would intervene. Well, we'll see. How many people would do cardiac cath and a percutaneous intervention in this patient? We've got a few takers. That's good. No moderators yet. How many people do surgery on this patient? Well, that's pretty good. You guys are pretty aggressive. I would say there are a lot of surgeons in the United States who would not do surgery on this patient. And the beauty of this is the only people that were wrong didn't raise their hand. Everybody else is right. Now, what I did is I did a 3-vessel Cabbage. The guy came out on a lot of drug. Trust me, you can't do this in every center. He was on Epi, Milrinone, Vaso, Levo. Now, I didn't need a balloon pump, but I had an art line in the femoral artery in case I needed to use a balloon pump, because I've been here before so many times where it doesn't work out the way it's planned. But it worked out great this time. They got extubated first day, post-op day 3, went to the floor. I sent him out discharged right before I came here. Well, we'll look at the same kind of situation with a little bit difference. The case I did exactly 2 weeks ago. He's a 59-year-old man. He has a non-ST elevation MI. His tropes go to 45. His creatinine's not too bad, a little bit higher, 1.3. This is what his heart looks like. Again, we'll play that again in case you get to see it. EF about 10-15%. These are his coronaries. You can see a pretty ratty LAD, a nearly occluded circ, and occluded right that reconstitutes. Almost the same as the last guy. So this is the only information we have. We'll do it one more time. How many people would use medical therapy alone? How many people would do percutaneous intervention? How many people would do surgery on this patient? Okay. And again, the only people wrong didn't raise their hands and participate and commit, because you got to do something. If this is your mom, your dad, your brother, your sister, you got to make a choice. And it's okay to be wrong if you try your best. Well, what we did was both. This guy was in shock. I didn't give you that. We put an impella in. We balloon angioplastied the OM with the expectation that he'll recover and get a coronary bypass when he's healthier. Well, this is his course so far. We did an angioplasty. He developed a GI bleed, did a scope, clipped the bleed. After he was in bed for about 2 weeks, he did get extubated after about a week or so. He was in bed in the hospital for a couple of weeks. I ended up doing a Cabbage, leaning the LED, 2 veins. Really hard to get him off pump. I mean, really hard. A lot of drug. Thought about doing it. I couldn't get a femoral art line in. Thought about doing an intra-chest balloon pump. Got him off. Actually did pretty well. Weaned some inotropes. Exited him the 3rd day. He developed heparin-induced thrombocytopenia because he'd gotten so much heparin in the hospital. He got reintubated post-op day 4. He arrested on post-op day 5. We did active compressions with CPR for 20 minutes. I ended up opening his chest at the bedside in the ICU. Now, I finally was able to put a balloon pump in. Closed the chest post-op day 8. Actually took the balloon pump out post-op day 9. He's got a trach and a peg, but he's going to be there a while. The course is evolving. Now, these patients are not so different if you're looking at all the little numbers, but they're having dramatically different course. And this is one I wish I could take back, or at least plan it differently. We don't have a lot of guidance for this. This is a nice paper, though. It's by Dr. Vasquez. He and Bono wrote this after the Stitch trial. And it shows who should you operate on, who should use medical therapy for. And actually, it's kind of complicated. The people that with a sicker hearts but are relatively healthier probably should get bypass. The people who have not as sick hearts but are a lot sicker ought to get medical therapy. And I'm only going to go over one study, or well, a couple, but really one study that really kind of teases us out. Before I get there, I'll say this is why. We know historically we've always believed Cabbage is better, especially with worse ventricles. And that's based on a lot of retrospective data, not some prospective, some subsets of prospective, but as we just heard, the stents were different. Everything's different. And certainly medical therapy has gotten a whole lot better. The only study that compares medical therapy versus bypass surgery in the current era is the Stitch trial. And I have to admit, embarrassingly, I didn't want to participate in this trial because I thought it was unethical to not give patients bypasses in this group. Well, like I said, the more I know, the less I understand. What was the Stitch trial? For those of you who don't know, New England Journal article published, about 1,200 patients randomized into medical therapy versus coronary bypass. And what did it show? All-cause mortality, there was no difference. And this, again, is in low ejection fractions, meaning less than 35. No difference in all-cause mortality between the two groups. And actually, the only difference was in secondary outcome, death, and rehospitalization. So there maybe was a rehospitalization benefit, but that's about it for bypass over medical management. Well, the interesting thing is, well, add the crossover, right? So about 10% in each group. This was intent to treat, so about 10% crossed over each way. And so we look at on-treatment analysis because it helps you understand the data. What happened to the people who actually got the therapy instead of who were supposed to get the therapy? Well, initially it looks like there was a benefit to Cabbage over medical management in terms of survival, but you do a multivariable analysis and that goes away. What there was an increase of quality of life. That's it. And it wasn't even that great 36 months out. So before we tease this out a little bit more, let's understand the data a little bit more, because the next thing is, well, maybe if we chose the right patients for Cabbage, the ones who had viability, they would do better. And that's what I thought for sure. Choose ones that you're making a difference on. That'll work. So we have information. We have actually good viability tests on about 600 patients, and about 600 of them, we don't have any viability. So we look at the 600 patients with good studies. About 500 or so had viability, and about 100 did not have viability. Well, looking at the whole group, there were very different patients as suspected, right? The non-viable patients were a lot sicker. The viable patients were better. They had better ejection fractions, better end diastolic volumes, better end systolic volumes. So, not a surprise, all comers, no matter what therapy you used, with viability in the green, you had a better survival than without viability. With viability, you had lower cardiovascular mortality than without viability. And with viability, you had less combined endpoint of mortality and CV hospitalization. So that's good. No surprises there. Well, this is where the surprise comes in. When we looked at Cabbage versus bypass in these patients, now we're getting a smaller subsets, but these are the only data we have. Let's compare those in both the viable and non-viable groups. These are actually, let's look at the demographics. These are very, very, very well-matched patients. There's no differences, and it doesn't even look like there's a close difference in any parameter or value in all the demographic data. So it's a pretty good comparison, I think. Well, what happens? Well, when you look at it, in the patients without viability, in the pink on the left, there may be a little bit of benefit from Cabbage. In the patients with viability on the right, there's no difference whatsoever. None. Cabbage versus medical management. And when you break out the hazard ratios, actually, they both overlap 1, so there's no real difference after you add the confidence intervals. So what does that mean? That really makes me not know anything about who to treat. Now, there are limitations, and these are important to recognize. The lack of viability in all patients, right? We only had viability in 600 of the 1,200 patients, so we might have missed something, and with a bigger number, maybe we would catch something. This is one of the biggest limitations. We saw earlier a lot of two great talks on terms of viability testing. Now, these were SPECT studies and Dobunin echoes. No one even talked about Dobunin echo in all of the day. There were no MRIs, no PETs. I personally use MRI in everybody who can tolerate it. Now, when you break this out, actually, the patients that just had the nuclear med scans, that wasn't so bad. A small segment had Dobunin echo, and that didn't help anybody predict anything. And there were differences between those two. So those are some of a few of the main limitations. The results, this comes directly from Bob Bono's slides. I copied these, and I got his permission. The stitch demonstrates a significant association between myocardial viability and outcome, but this association is rendered non-significant when subjected to multivariable analysis that includes other prognostic variables. This stitch failed to demonstrate a significant interaction between myocardial viability and medical versus surgical treatment with respect to mortality, whether assessed according to treatment assigned, intent to treat, or treatment actually received. The implications in patients with coronary disease and LV dysfunction, assessment of myocardial viability does not identify patients who will have the greatest survival benefit from adding Cabbage over aggressive medical therapy. So does Cabbage help anybody? Well, actually it does. And to their credit, they also looked at several other parameters. They looked at 6-minute walk and physical activity score. Lo and behold, if you had a patient who could walk more than 300 meters in 6 minutes, actually they did better with Cabbages than over medical therapy. If you had some debilitated patient who wasn't going to do anything afterward anyway, they did the same. Well, that kind of makes sense. And then if you look at the sicker patients, now these aren't necessarily the sicker COPD we talked about or dialysis, but the sicker in terms of multiple things that can go wrong. Like if you had more multiple multivessel disease or worse coronary disease, if you had a lower ejection fraction, if you had a larger end systolic volume, actually if you had multiple factors, you did better with bypass. If you had only one of those factors, you did the same with bypass or medical therapy. So let's figure out what all this means, and let's look to the guidelines we talked about, which once again are guidelines and they're not rules. Well, in the 2012 combined guidelines from the ACC AHA, they recommend it's a 2B indication for EFs of less than 35%. If you have multivessel disease, no left main disease. Well, I really, I used to say 2B is good. Now I can't stand 2B because if you do, from my interpretation, 2B now is if the patient does well, you are right. If the patient does poorly, you are wrong. So it doesn't really give you any guidance or support. I mean, you're really kind of out to dry on this. Well, what about the European guidelines? Well, this is going to be important because it's different. I mean, it's very different. They recommend Cabbage should be considered in the presence of viable myocardium, irrespective of left ventricular end systolic volume. And this is a level 2A evidence. 3, on the bottom, revascularization in the absence of evidence of myocardial viability is not recommended. So the Europeans are saying, if you have viability, do it. If you don't have viability, you cannot do it. You'll do more harm than good. Well, the 13 guidelines from the ACC, actually class 2B, the bottom one, Cabbage may be considered with the intent of improving survival in patients with coronary disease and operable coronary anatomy, whether or not viable myocardium is present. So we haven't even agreed across continents. It doesn't really help us very much at all, I don't think. And it makes me say, I don't think anybody really knows what to do. The one thing we do know is if you have good pressure, basically if you treat medically, whether or not you use a bypass, it's a good thing. And we know we're making a difference as the medicines have gotten better. So these are class 1 indications. So whether or not you do bypass, don't just do the bypass. You have to use aggressive medical therapy in all these patients. Well, that part's easy. Where do you figure out what to do next? And that's why I encourage you, this Vasquez article again, it's worth looking at, and it kind of gives you some help in terms of what direction to take when you've got my next Friday's case. So what do I do? If you look at it, this is a little different. And actually, I'm sorry it's not looped. Once again, I'm getting MRIs in these patients, and I look at the ventricle itself. I start with looking at the ventricle and saying, what am I seeing? I see thick myocardium in this one, and that's different than the other ones. You see that thinned out area though? And again, I'm sorry it's not looping, but that very thinned out area, that's scar. No matter what you plug into there, it's not going to do any good. And I reminded when I used to do a lot of doors. Now this is a patient I still might do a left ventricular reconstruction on, and I still do some of these, although I've cut it back quite a bit because I don't do it for akinetic segments. I only do it for dyskinetic segments. More blood to that area is not going to matter. It's just not. On the other hand, if there's an area that looks thick, there's got to be something alive there, right? And so I start with that. Do I think giving more blood to that ventricle is going to do any good or not? And then along the way, I also go and think about it. Do I think I can survive the patient? No matter what Dr. Spray said about risk-adjusted mortality, the patients come to you for an operation, they expect to live afterward. There is no mortality that's worth it. On the other hand, you have to take a balance, but you really want a 0% mortality. You can't always be right, but you want to be right as much as you can. I can get it by any dialysis patient through a Cabbage, unless they have LV dysfunction. It's incredibly hard to manage their fluid shifts afterward. So if you're a dialysis and low EF, especially with lousy targets, and I don't think I'll be able to find something, not really going to be so excited about that case, probably going to stent it. If you have liver disease and a low EF, you're stented or you're on your own, and you're going to get medical therapy. If you're 80 plus, now I've seen a lot of good 80-year-olds, but as soon as you hit 85, I don't know, I don't think I'd do it. Now, if you were healthy, had a normal heart, that kind of stuff, it's different. I'm talking about on average. So the other thing that's really important is the RV alive or not. Both those patients I showed you, those RVs were alive and pumping. It's hard. It's really hard to recover these patients. You have a dead RV and a bad left ventricle. If you had a dead RV, it's really incredibly difficult to manage. Now, you can do it, but I wouldn't embrace it right away. Then if I think I can survive the patient, am I going to help the patient? Do they have heart failure? Are they be readmitted? Are they bedbound? Are they mentally attacked? Or am I just going to do this and I'm going to stay in the hospital or some facility forever? Well, those are the things that I consider. And I'm sorry I don't have an answer for you, but I really have come to believe this is a lot more art than science. And so the only way to do it is take a multidisciplinary team, as we suggested, and really sit down, not just about what the guidelines say, about each individual patient, and are you going to do good or not? Because all we want to do at the end of the day is we all want to help and do good and not bad. Thanks very much for your attention.